Endogastric Solutions is supporting Esophageal Cancer Awareness Month, which is in April. And we are offering this beautiful flower lapel pin to some of our Facebook users. And for those of you who have RSVP'd to the event, we are giving these away to you, and we will direct message you to get these to you. In addition to that, at the end of the event, we will be giving out additional lapels at the end of the event. So if you want to ask a question for either Dr. Ihde and or Carol today, and or also comment, we will pick a couple of people on Facebook to also receive a lapel pin. So with that said, the 5 people that won today is Allison Williams, Connie Gonzalez, Suzanne Page, Dave Miller, and Dolores DeOka. So thank you so much for registering. I hope you're on today to help to listen to our live TIF Talk. Again, we're here with Dr. Ihde and Carol. So we're going to go ahead and start.
Okay.
So Dr. Ihde, thank you again for being here. Dr. Ihde, you know, we're going to talk about GERD today and acid reflux. So can you kind of just give us, you know, your clinical description of what GERD and acid reflux is?
Right. So technically, acid reflux or gastroesophageal reflux disease, GERD, is when the fluid in the stomach gets out of the stomach back into the esophagus. And most people, you don't walk around and say, I have GERD. They'll say what symptoms they have. So they'll have heartburn. That's kind of the thing that starts it. One of the things that really drives them to seek treatment is regurgitation, when they're laying down and fluid rolls up, or they feel it coming up to their throat. Sometimes they'll wake up in the middle of the night with a sour taste in their mouth. That gives a lot of secondary things, like, you know, they end up with chest pain,
right,
and then cough and sore throat and recurrent sinus infections, maybe even ear infections. Things that people sometimes don't realize are associated with things like cavities, right? Because it soaks your teeth in acid.
Right.
And so a lot of times they'll go to the dentist and they'll say, oh, by the way, you have reflux disease, and that's how they realize that they have it.
Wow.
So reflux is when the fluid comes up into the esophagus, and because it's got bile and acid and other digestive enzymes, it tends to injure the esophagus and it hurts.
Right. So Carol, maybe you can kind of give us your experience with heartburn and acid reflux. How long have you been experiencing?
Since about college.
Okay, wow. Okay.
And I was a 4-pillow sleeper, and then ended up sleeping mostly on the couch.
That's because of the regurgitation part, right?
Right, having
You'll
to
wake
sit
up
up.
in the middle of the night. Yeah.
What about foods? I know that food can
Orange
trigger
juice, chocolate, wine,
just
all of those, and you know, lasagna, and it just didn't depend. Every once in a while, it might have been the chocolate cake or something like that.
Sure. So how were you being treated for your GERD and acid reflux for all of those years, you know, prior?
Well, the lifestyle changes.
Sure.
You don't eat it.
Right.
And then like Nexium, and then Protonics,
Sure.
that type of thing.
Okay.
And then that's when I went to Dr. Ihde.
So prior to seeing Dr. Ihde, you had been using PPIs. You've been trying to change your lifestyle, your diet, to help with that. And so I know Dr. Ihde. For some of you that don't know, Dr. Ihde has been doing what is it? Over 650 TIF procedures.
Over 650
now.
TIF procedures with the hiatal hernia repair as well.
Right.
I started in October 2009, so I've been at it for a little
10
while.
years.
Yeah, 10 years.
Wow.
It's been 10 years, Dr. Ihde. It's been 10 years. Well, thank you for sharing that. What options do you normally give patients that say they come in, or they are diagnosed with GERD and acid reflux, like even prior to any surgical treatment option?
Yeah, but by the time they come in and see me, we sort of have come to the conclusion that they need more than basic lifestyle changes. But we always start with lifestyle changes, right? Just like Carol was talking about, you want to avoid the trigger foods. And so you mentioned a lot of them actually, chocolate, mints, alcohol certainly tends to be more acidic food, tomato-based foods, right? Tomato soup, lasagna, spaghetti, that
All
sort
the
of
good stuff.
All the good stuff, right? And barbecue and that sort of stuff. So that's when you're having heartburn because of those foods, what we call trigger foods.
Sure.
That's the very first thing. And what that is heralding, or what that's telling you, is that because of that food you had extra fluid or extra content in the stomach, it got into the esophagus and injured the esophagus initially.
Right.
Now, if that feeling persists, you start off with antacids, Tums, Mylantum, Maalox, Gaviscon, and that'll buffer the acid initially that's in the esophagus, and you should get pretty much instant relief from that.
Sure.
But then if you don't, and it's 2 hours later still burning, then you've probably injured the lining, what we call esophagitis. It's an erosion. I tell people it's like a rug burn to the lining of the esophagus. So even though you've neutralized the acid, anything that's touching it kind of hurts.
Right.
And that's when you know you need medications. So there's really 2 stages of medication. The first medication blocks the signal to tell your stomach to produce acid. And so you can block about 60% of the acid production. And within 8 weeks, you should get healing of that. That's called an H2 antagonist. The common forms are Zantac or Pepsid AC. Almost all these medications are over the counter now,
Right.
so people can get them pretty much whenever they want. And like I said, the trial is usually 8 weeks to see if that doesn't control it, and then you should be able to get off the medication. If it's just due to intermittent exposure.
Sure.
Right?
Sure.
And then if that doesn't work, then there are stronger medicines, and we call those proton pump inhibitors. That's the PPIs. It's the pink pill, the purple pill, Nexium, Prilosec,
Right.
Dexalent, Protonics. There's a lot of them now. And all of those medications actually block the real production of acid in the stomach. So 90% of the acid is blocked. And again, it's an 8-week trial. And typically you'll repeat that trial. So
Sure.
there's actually kind of a long progression from lifestyle changes, antacids, H2 blockers, and then PPIs. So you'll be at least 6 months into it or more before you decide, I'm still having symptoms, I can't get off the medications. That's a clue, really, that there's something else going on. It isn't just your stomach responding to the foods that you've eaten. It isn't just an intermittent problem.
Sure.
You're probably getting ongoing, constant exposure.
Right.
And that's due to anatomic changes, and that's why surgery comes into play.
Right.
Is medicines can affect chemistry, but they can't affect anatomy.
Right.
And surgery affects anatomy.
Right. Right. Thank you for that explanation.
That kind of long-winded.
No, that's very great. I know that our Facebook users like to understand it a little bit better, so thank you for that.
Yeah.
Now, Carol, I understand that you were seeing a GI at the time, and you were on the PPIs.
Yes.
And what did he tell you?
To get off them immediately, because I had already been on them for about a year plus.
Wow.
So
Okay.
he said to get off of them immediately.
Okay. And that's when you were able to
Yes.
meet Dr. Ihde and
Yes.
finally say, I've got to do something
Yes.
about this now.
Timing is everything.
So can you? There's a lot of studies and a lot of talk about long-term effects of PPIs these days.
Right.
Can you talk a little bit about that or explain?
Yeah, so proton pump inhibitors came out in the 1980s, mid-1980s, and the initial feeling was that they were very safe. They did see some polyp formation in study animals, but they're benign. They don't cause cancer or anything, so they thought they were very safe. And then with time, there have been studies that come out with a variety of things that are associated with it. More pneumonias, more colon infections, colitis. We know that the heavy metals, which is iron, magnesium, and calcium, require acidification to be efficiently absorbed.
Okay.
And so if you block the acid of the stomach, of course, you don't absorb those as well. And there are studies that indicate that particularly for women, they're not absorbing enough calcium.
Okay.
So they'll get wrist fractures, osteoporosis. They'll get wrist fractures, hip fractures at a higher rate if they've been on them for a long time.
Interesting.
And then, you know, the one thing that's sort of really caught everybody's attention is esophageal cancer.
Right.
So we'll talk about that. It's
Yeah.
esophageal awareness.
Yes.
And so the incidence of esophageal cancer started climbing since the 1980s, and it's been exponential, meaning we have about a 600% increase in the last 30 years.
Right.
So, you know, the timeline is along with the amount of prescriptions that went out and the number of doses of PPI that are getting consumed by people, because reflux is very common. It's about
Right.
one in 5 patients has
It is.
reflux that they have to treat every day. So, you know, the study is that the medicines don't cause cancer, obviously, but they do allow for the physiology to change, and that exposes then the DNA to the cancer-causing agent, the carcinogen.
Right.
And so that becomes the problem. So our general recommendations now are not to be on PPIs for long periods of time. Definitely not more than 5 years. And like your doctor said, you know, you'd been on it for a year. You've already figured out, you know, it's not a chemical process.
Right.
It's a mechanical process or an anatomic process. And so you have to shift gears and change your treatment focus on treating what's actually going on.
Right. Right. Okay. So let's talk about the TIF procedure.
Sure.
I'll let you explain what the TIF procedure is, and then maybe Carol can give us her experience after having the TIF procedure. if you
Right.
don't mind.
So there are, in the anatomy of the esophagus to the stomach, the esophagus goes through the chest and then through an opening in the diaphragm we call the hiatus, and then is folded into the side wall of the stomach. So a lot of people think of the esophagus coming straight down onto the top of the stomach, but it doesn't. It comes in from the side, and that fold creates kind of a flap valve, and that creates a pressure phenomenon, and we refer to it as the lower esophageal sphincter, but there isn't really a sphincter there. It's really a pressure ridge, and that keeps things from getting out of the stomach into the esophagus. So changes in 2 parts of the anatomy make you lose that pressure ridge. The first is what we call the angle of His. That's the folding of the esophagus into the stomach. The stomach comes off of the esophagus. And then the second is the opening in the diaphragm gets bigger so the stomach can pull through into the chest.
Okay.
And that's important because the chest is a negative pressure environment. We inhale air through negative pressure. That tends to pull open the valve instead of pushing it closed. Below the diaphragm, it's positive pressure. So all of that feeds into how the mechanics of how all this works.
Sure.
What the TIF procedure does is it folds the fundus back onto the esophagus. So we're able to recreate that flap valve portion. But a second part that is part of what I've been studying is the hiatal opening and the hiatal hernia. And we knew from the history of surgery that always needs to be fixed. Sure. And when we came up with this new fundoplication technique, transoral fundoplication, incisionless fundoplication, we then had to go back and kind of relearn the history that we already knew.
Sure.
And really, you know, surgery had not been offered for about 30 years. So it's 3 generations of physicians really that you're talking about that have been told, you know, not to do surgery.
Right.
Because of side effects of the older surgeries.
You're talking about the Anacin.
Of the Anacin
Nissen
fundoplication,
fundoplication,
right.
right,
And so
okay.
what got me interested in TIF was that the initial study showed that we weren't having those side effects.
With the TIF procedure.
With the TIF procedure.
Right.
And so it made sense to me since I knew reflux was an anatomic disease. It's really a surgical disease. We would need to go back and find something that would do as well as the Nissen,
Without this.
but without the side effects.
Right.
And studies showed that TIF was the procedure that did that.
Right.
And then we had to figure out the hiatal hernia part. So we figured that out. and now we typically do both. It's what people have to realize is the anatomic changes aren't like one day it's okay and the next day it's not.
Right.
It's more like you wear out your tires on your car, right?
It's a good analogy.
Is you first, first the angle of His falls, and then you start to dilate the opening, and then it herniates. So there is a spectrum of patients that do well with TIF alone, and those are patients that have mainly heartburn, esophagitis, and they don't have a hiatal hernia when they're evaluated.
Sure.
And then there are patients that have already developed a hiatal hernia, and they're in the process of developing it. And when to intervene and when to repair that has been kind of the subject of our research, and we figured that out now. And so if you do have a hiatal hernia, you're much better off getting that fixed at the time that you do your TIF.
You do it together.
Your outcomes are much better.
Right.
Right. So there's a combination. There's actually 2 procedures that are being performed.
Sure.
Hiatal hernia and TIF.
Right. Okay. And so, Carol, did you have a combination procedure?
Yes, I had the
right?
combination.
Okay.
Yes.
And so, what was your experience? And when you went to see Dr. Ihde, did he explain to you all the different treatment options?
Yes, Dr. Ihde has a whiteboard, and he draws pictures and makes it very much, shows you exactly what he said as far as where all the problems are.
Sure.
And is very explanatory in what he's going to do.
Right. So did you know about your hiatal hernia before the TIF?
No.
No, so that
No,
was
I did
all
not.
new to you?
Yes.
Okay.
That was in the testing prior to.
Okay. And so after you met Dr. Ihde and he talked to you about this treatment option, I'm bringing this up because I was so surprised. How quickly was it when you came to see him and said, I think I want, a treatment option, surgical treatment option? How quickly was it until you were able to come in and
Well,
get
it was, I had already had like a scope, and then
Right.
I had maybe 1 or 2 tests that I had to do, but it was about a week.
Wow, that quick.
Well,
So let's talk about that.
She
There's-
had already been
yeah.
through several stages,
Thank
right?
you,
She'd
yeah.
Oh, yeah.
already done
Yeah.
the lifestyle. She'd been on PPIs
Long time.
for a long time. She'd already had her endoscopy. So we always do endoscopy.
I was going to ask about the workup.
Yeah, because we need to see the anatomy. We need to do measurements. We need to know how big the hiatal defect is if it's there. We like to do pH testing. But in addition, I also look at other things that are going on. So for instance, we want to make sure the esophagus is working.
Sure.
A lot of patients have had reflux for a long time, and they have scarring in the esophagus, so they have trouble swallowing. And so typically to treat that, they'll go down and they'll balloon that to break up the scar tissue.
Right.
But they're going to have to relearn swallowing after the hiatal hernia repair and TIF. And so we want to know for sure
If they can.
what's going on in the esophagus, so we
Sure.
test that.
Okay.
We want to know that once that valve is in place, is the stomach going to empty normally underneath the valve?
Right.
Because otherwise, if it's not, they're going to feel very bloated and kind of distended.
Okay.
And that's a separate condition, but we want to be able to treat that as well. And there
Okay.
are medical and surgical treatments for that as well.
Okay.
Another condition that sort of mimics reflux symptoms is gallbladder disease.
Oh,
If the
interesting.
gallbladder is functioning normally or not. If it's not, people have what's commonly called dyspepsia. They kind of feel some heartburn. They feel kind of gassy and bloated. They belch a lot. Maybe foods don't go down as well. Cramps and diarrhea even, right? So if we're going to be in there operating on the hiatal hernia and doing the TIF, but it's the gallbladder that's causing the symptoms, they may not get better,
Right.
right? And so we
you
want to
wanna
be able
see
to address
everything
that.
first, right.
Plus, we could address the gallbladder at the time of surgery as
Right.
well.
Okay.
So you sort of, testing the entirety of what we call the foregut, the esophagus, stomach, and the first part of the small bowel, the duodenum, to make sure all those components are working,
Sure.
and then address the things that aren't.
Okay.
So it's not just about
reflux.
it's about
Their whole-
foregut health, really.
Right. I think we have thank you for that. I think we have a question from a Facebook user.
We do.
Karen?
This question is for Dr. Ihde,
Yes.
and it's from Lori. She has asked if you've previously had a Anacin that became unwrapped, can you have a TIF now? And she also has a hiatal hernia.
Right. So that's a very good question. A lot of patients have gotten Nissen fundoplications. The most common cause of a Nissen failure is actually the hiatal hernia repair falling apart. So we do go in and we re-repair the hiatal hernia, and then the Nissen will oftentimes slip off onto the stomach or come apart, and we do what's called a TIF over Nissen. And that was written about, maybe 8-9 years ago, and it's been a part of my practice since. So the short answer is yes.
Okay, fantastic. Did we have another question?
We do. We have a question for Dr. Ihde from Kim. What is the recovery time for the TIF procedure, and do I make any lifestyle changes after my surgery?
Right. So for my practice, we do the hiatal hernia repair and then the TIF at the same time. And so I typically like to keep patients overnight in the hospital.
Sure.
And this is just an observation period to make sure they're doing okay, get them started on a diet, and check some lab work in the morning. And if everything looks good, then they can go home. Typically, people are sore from the incisions for 3 or 4 days. When you have surgery in the abdomen, it'll oftentimes cause shoulder discomfort. So they'll have that for a few days. Sometimes that can last a couple of weeks, and we found that like compounded medication helps with that. And then they have to go through a 6-week diet. So most people are back driving within 5-6 days, or back to work within 2 weeks, but they do have this 6-week diet. Now the interesting thing is, when you do surgery at the top of the stomach, it tends to make people feel full early. So they don't get necessarily really hungry with the diet. It sounds bad, but it turns out it's not as bad. Yeah. It starts out with full liquids for 2 weeks.
Okay.
Then pureed foods, kind of like baby food or anything, put into a blender for a week. And then soft food, anything you can smash with a fork for a week.
Okay.
And then I'd sort of do a stage of regular foods where it's stuff that you chew, but beef and chicken and rice and bread are a little bit harder for the esophagus to push down.
Okay.
And so I asked them to lay off of that for an extra week and then back to that the week after. The thing is we talked about that ridge of pressure.
Right.
And when you have reflux, it's gone. So the next day after surgery, you got this new big ridge of pressure. Your esophagus isn't used to that. And so like any other muscle, it has to gain some strength back, and it also has to coordinate its contractions. And so I tell the patients it's like rehab for the esophagus to go through that diet, right?
That's a good way.
Is the esophagus learns to contract thicker and thicker foods, coordinate their contractions, and when they follow that diet, they seem to do very, very well.
Yeah. Well, I know you were telling me that it was great.
Yes, and it's very well laid out, and you also lose a little weight while you're at it. So it's
You
a
said you
twofer.
lost 15 pounds
Yeah.
or so?
Yeah.
Wow,
So
that's
I'm,
fantastic. Yeah. You look
Now
great.
he
Nice
is-
little bonus.
yeah,
I
but he
tell
always
everybody
says,
they regain their weight.
Yeah, you'll
though.
regain it. And I said, no.
She hasn't though, which is nice. Yeah.
So for you, that's one of the big questions we get a lot from our Facebook users is, oh my gosh, that diet. Every doctor's different too. I know some doctors that
there's modifications,
there's
but it's pretty much the same.
Yeah, pretty much the same. So how was the progression in the diet for you?
Was not bad.
Okay.
Was not bad. And again, like you said, your appetite does not, you don't have an appetite really.
Yeah, for the first couple
Yeah.
of weeks. That's what everybody says.
Yeah.
Yeah.
I agree with that.
A little pressed to explain that, but I think that the edema at the top, that's where the stretch sensation comes from for fullness. So
Yeah, just
I think
not
it's
healthy.
affected by the edema. Yeah.
Interesting. So I know I asked you this earlier. What was the first food that you ate that made you realize I don't have reflux? I can eat this.
I ate lasagna.
And that was one of your trigger foods.
Yes.
And no more
No more.
reflux.
No more.
Yeah, so the interesting thing is
Yeah.
patients can go back to eating things that would have caused them reflux. And I tell them, if you're really hitting it hard, if you're going to straight jalapenos, maybe
I hope you're not doing that.
No.
maybe
no.
a Zantac 30 minutes beforehand to help out. But most of the patients, even with that, don't have any reflux. And the only thing we ask them to stay away from long term is carbonated beverages, sodas
Okay.
basically.
Sodas.
A lot of people ask about beer
Yeah.
or
I did.
champagne, and that's fermented, so it doesn't produce the amount of gas. We don't want to over distend the stomach. which can pull on the repair.
So there's a difference between
There's a difference
soda
between soda, carbonated beverages, and
versus
fermented beverages.
Yeah.
So
You
it's
asked
the
about
carbonated.
that,
Oh,
Carol.
yeah, I did ask about
We do
that.
want to know.
I want
Yeah.
my beer.
Yeah.
That's fantastic.
Nice stout.
Oh God, yeah,
Oh,
nice.
thank you. Yes.
So after now that you're how many? February was your
February.
procedure?
So about almost 2 months.
And then when were you able to start? So after 6 weeks after, so
Yes,
you're just
yes.
fairly coming off.
Right.
Of,
Right.
so is there anything you want to share about the
I
experience?
look at my medicine cabinet, and all I see is Tums and Maalox, and I don't have to use it ever, and I love it.
That's fantastic.
I am very pleased.
Pretty significant change in
That
life.
is
Yeah.
a significant change.
Yeah.
I
When you
asked
have Tums in your car, all cars.
to make sure you
Yes,
have it.
Yeah,
all
full
cars.
supply,
Yes, definitely.
That's incredible. I think we have another question from Facebook.
We do. This question's for Dr. Ihde from James. What's the difference between the TIF and the LINX procedure?
So there's in the history of medicine, there have been a lot of sort of theory about the mechanics of the gastroesophageal junction, that ridge of pressure. We know it's there, what's causing it, how does the body create a ridge of pressure at that area. And so what TIF is doing is it's sort of restoring the normal anatomy, and that reintroduces that pressure zone. LINX does it a little bit differently. They're using sort of a bracelet of magnets that compresses on the outside of the esophagus to create a pressure zone, what they're calling sphincter augmentation. I don't perform LINX because I don't think that from a physiologic standpoint that's normal. I think that the pressure is normal, but the way they're doing it isn't quite normal. And so that's why I don't do it. I know other physicians have a different view of that, but the TIF was just working so well for us that I never went to that direction.
Okay.
Yeah.
Sure.
We have another question for Dr. Ihde from Allison. Is it safe to become pregnant after you've had a TIF?
Yes, the short answer is yes, but the thing that causes recurrent reflux after Nisons as well as after TIFs is a breakdown in the hiatal repair. We're still studying, how's the best way to do that? Should we be doing it with this kind of stitch or that kind of stitch, or should there be an implant there? The studies really haven't shown us a better way of doing it. So there is a failure rate to the hiatus. If you get pregnant, the pressure may cause that to come undone.
From the hiatal hernia,
From
not
the
the
hiatal
TIF,
hernia.
though.
Not so much from the TIF,
Okay.
but from the hiatal hernia. But if you have a hiatal hernia come back, eventually it can wear out the TIF.
Okay.
So the good news is it's actually fairly easy to go back in and re-repair the hiatus and redo the TIF if it needs to be done, compared to the Nissen fundoplication, which is actually a fairly difficult procedure.
Right.
And so even that as a kind of a side benefit for us surgeons
Sure.
is a nice benefit to have. It's easier to redo
repair or
if we do
redo.
have to do it.
Yeah.
Yeah.
On a TIF. Okay.
Yeah.
Another
I
question?
have another question for Dr. Ihde from Mark. His question is, my pH testing and endoscopy was done 2 years ago. Will I need to get a more current testing prior to my consultation?
So it depends, of course, on what your endoscopy and pH showed. If your endoscopy showed a hiatal hernia that's just starting, not very big, it may have changed between now and then, so we would have to reassess it. If your pH study was positive, then it's unlikely that that's getting
Change.
better on its own.
Sure.
So the pH study is probably good, but the endoscopy, we may want to relook at that.
Okay. Fantastic.
And we have another question
Sure.
from Mason for Dr. Ihde, and he would like to know, is TIF effective for LPR? What are the rates of success for Gerd and LPR?
Right, so we talked about GERD, reflux, fluid coming out of the stomach into the esophagus, and those signs and symptoms. But there's a whole other subset of patients that we call laryngeal, pharyngeal reflux, LPR. And what it is are the throat signs, hoarseness, chronic cough,
Asthma? No.
Asthma, 80% of adult onset asthma is reflux related. The sinus infections and ear infections and the tooth caries. So all of those fit into sort of the diagnosis of LPR. And the problem is there's not a direct test for LPR. So when you have the symptoms, we look for reflux. And if you are proven to have reflux, there's an 80% chance that your LPR symptoms are due to your reflux. And so if you fix the reflux, the LPR gets better. So again, another kind of technical answer, but it's important to understand there's lots of reasons why people, for instance, have a chronic cough. That's the most common thing. And only a subset of those patients is it going to be reflux. So if you have a cough but no reflux, reflux procedure obviously isn't going to fix
Right.
Right, so we want to make sure you actually have reflux before we operate on you.
Okay, fantastic. We have a lot of questions
One
today.
more, all
Yeah.
right.
Let's-
One more question for Dr. Ihde from Amy. Is there a certain weight limit you need to be before you have the TIF procedure?
Yeah, that's a good question. So rather than weight, we use something called BMI, body mass index. It's a comparison of height versus weight. And if you look on the internet, there's calculators all over.
Sure.
Just put in your height either in inches or centimeters and weight either in pounds or kilograms. It'll give you a number. Typically, the number we look at is a BMI of 35. And BMI of 35, we begin to feel like the weight is contributing to the early hiatal hernia failures. And of course, then you get recurrent reflux. So if your BMI is over 35, we typically start to move towards weight loss and weight loss surgery, which is very, very effective, both for losing the weight and the other conditions associated with weight, but also for reflux.
Right. Okay.
And so a BMI of 35 is sort of the soft target. Definitely, I think over a BMI of 40, you should be looking at weight loss and weight loss surgery. Between 35 and 40, it may be that weight loss after your reflux surgery gets you below a BMI of 35. So that's sort of a soft target, BMI of 35.
Okay, fantastic, great. Do we have any other questions from Facebook? We're good? Okay.
Okay.
Well, Carol, I just wanted you to get a chance. If there's anything that if you could give someone some advice for someone who's been suffering from GERD and acid reflux for some while, or even newly, what would your advice be to them?
I would say get yourself checked out. See if the TIF procedure would be able to be helpful. Find a doctor, like I did, and it's a life changer.
That's fantastic.
Life changer.
That's awesome. Well, thank you so much for
Thanks.
sharing that with us
thanks.
today.
Hey.
Thanks for coming over.
And Dr. Ihde, thank you, of course,
absolutely.
for always being here and helping our Facebook users that are on. So with that said, we're going to go ahead and conclude. But before we do, I want to thank everyone for joining us today. We also want to talk about the giveaway, who won that based off of comments. But also, if you're wondering how to find a doctor in your area that offer the TIF procedure, you can go to gerdhelp.com. You can also follow our page, and you'll get a lot of information about the TIF procedure and GERD and acid reflux. So we're going to quickly name off the names of the winners. I think we've got a couple of people that were on earlier. Okay, so Patty Diaz, thank you for being on. We are going to be sending you one of these as well. Lori Lobs, Mason Matias, I'm sorry if I'm saying your names wrong. James Erica, Mark Howard, and I believe Allison Williams again. Thank you for showing up and being on today. So again, thank you very much for joining us today. We appreciate your time. And thank you again, Dr. Ihde and Carol, for being here. You guys have a fabulous day. Bye. Done?
Pretty good.
That was
nice
fun.
job.
That was
job.
good. Love
Good
it.
job.
Thank you.
That was awesome. It looks so good.
Yay. That was fantastic.
Thank you.
So can we
Thank you. Thank you.
Can we watch it on Facebook?
Yeah,
Is it
now
recorded?
it's gonna,
Now it becomes permanent?
it's permanent. There's no, no going back. There's no going back. Carol,
Do what now?
Accuse us of hiring an actress.
Yeah.
before you go, Carol, if I could get you to write you down, you can just write it down here.
I'm just gonna take this mic off before
Yep.
I walk home.
I know, and then